Good morning, everyone. My name is Mor Israely, and I'm a clinical dietitian. I have over 20 years of experience in the field of eating disorders, ranging from treating extreme eating disorders in hospital care to managing an eating disorder clinic for Maccabi Healthcare Services. I also have a PhD in the field of eating disorders from the Medical School of the Hebrew University. So now that you know me better, we can start. In recent decades, bariatric surgery has become the leading procedure for treating obesity. As we know from various sources, binge eating disorder is the second most common psychiatric disorder among candidates with bariatric surgery, right after major depressive disorder. Both disorders may affect the effectiveness of the surgery. Out of the obese population, those who seek bariatric surgery are more frequently diagnosed with BED, and their symptoms are more severe compared to the obese population that did not seek out surgery. We all know that sometimes the diagnosis of the disorder is made for the first time only at the pre-surgery interview, although the onset of the disorder had begun much earlier. One of the reasons for such late diagnosis is because patients are in denial. They hide the symptoms and they're ashamed of their inability to lose weight. In addition, there is not enough awareness among caregivers for this disorder. Our eating disorder clinic in Maccabi cooperates with the bariatric clinics to help those patients who struggle with BED before they go through the procedure and also after. I apologize. Today I will focus on those who continue to suffer from BED post-surgery. Here is a reminder of the DSM-5 diagnostic criteria for BED. The criteria talks about binges, and binges describes as eating large amount of food, larger than most people would eat in a similar period of time and similar circumstances, and a sense of lack of control over eating. Then another description of the binge is eating fast, feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feeling embarrassed about how much one is eating, and feeling disgust with oneself, depressed, and very guilty. We always say that someone who is fat and is happy with himself and with his body, he does not have any of eating disorders. So there is a marked distress regarding the binge eating in every cases of eating disorders. And the binges has to be at least once in a week for 3 months. But it's a little bit tricky, the criteria for the bariatric surgery patients, because eating large amount of food is impossible at the short-term period after the surgery. So these two marked red criteria are irrelevant, but lack of control does exist. And now we talk about a new term of binge, which is objective binge eating, which means eating small amount of food with a feeling of lack of control. All other criteria that are mentioned here do appear, and the patients, in most of the cases, start to feel it after around a year from the surgery, and they turn for help to help for those symptoms they feel. They start feeling unable to control what and how much they eat. They feel restlessness and obsessively think about food. Since the impulse to eat is strong, but it's impossible for them to eat large quantity of food, they become grazers, continuously eating small portions of comforting and calming food throughout the day. They also seek help since they stop losing and even regain weight. For the bariatric patient, this means complete disaster and devastation, especially after all they went through, all the programs they participate in, the many kinds of diet they were on since they can remember themselves, the negative attitude, in an understatement, they received from their surroundings, and the many failures throughout their life have led them eventually to turn to surgery, the last option. They come to us frustrated, depressed, desperate, believing nothing else could work for them, especially after they had such high hopes given the risk in the drastic procedure. Our program does not provide an immediate solution. There is no magic. It involves hard work and ongoing efforts. It's not easy for many of them to go through it, and sometimes they give up. But those who do stay realize and understand that this is truly the emotional and cognitive process they had to go through years ago. The Eating Disorder Clinic provides comprehensive treatment for adults, children, youngsters suffering from all kinds of eating disorders. In our clinic, we have a multidisciplinary team of experts that include clinical dietitians, psychiatrists, pediatricians, psychologists, and social workers. There are many forms of treatment: individual and group therapy, therapy for parents and for their children, family therapy, etc. For those who suffer binges, as in binge eating disorder or bulimia nervosa, we offer CBT group therapy. During the past 3 years, we started to include the bariatric patients as well in those groups. The group treatment is based on the CBT enhanced protocol with few adaptive changes. The CBTE manual was developed by Christopher Fairbairn in 2008 and is a well-known therapy. It had been studied for years and proven as very effective for those types of disorders. The CBT manual deals with the processes of maintaining the eating disorder psychopathology. It uses specific strategies and therapeutic procedures to achieve both cognitive and behavioral changes. Okay, so the group setting. The group meets once a week for 20 weeks, and then once a month for follow-up meetings. The group is guided by 2 therapists. One is a clinical dietitian, and the other is a social worker or a psychologist. There are 6 to 8 participants in each group. There is a mandatory attendance, and they are home assignments they need to make. Other than that, they receive also psychiatric treatment as needed and individual psychotherapy. Here is an example for a self-monitoring table. I would like to demonstrate one of the tools the CBT therapy uses to promote food and emotional regulation. So here is an example for a self-monitoring table. Don't worry, it's not an eye chart. It's just to get expression. This patient was a year after sleeve surgery, wrote it while in our program. In this example, there are no meals, no scheduled eating, only unsuccessful attempt to avoid eating, and as the day passes, we see the increased distress and frustration and the use of sugars to reduce them. Self-monitoring is essential and important role throughout most of the therapy. It enables further understanding of the eating disorder and identifies elements that maintain the disorder. Second, and more importantly, self-monitoring helps patients to be more aware of what is happening in the moment so that they can begin to make changes to behavior that may have seemed automatic or beyond their control. The records also help identify the triggers and the thoughts that activate the binge. And finally, it's a tool that gives the therapist knowledge about the quality of food, eating schedule, and the patient's progress. The participants deal with and work on issues like impulse control, self-regulation, eating habits, automatic behavior, weight and shape concerns, body checking and avoidance of the body, the use of extreme weight control methods unsuccessfully, negative thoughts, and dichotomous thinking. Weight reduction is not the goal of the therapy, but it's a positive side effect of it. The effect of the CBT groups is being studied and researched in collaboration with the Hebrew University under my supervision. We did not analyze it yet, but we see a reduction in grazings and binges. We see more regulation of eating. We see they eat healthier meals, being aware of their thoughts and how it affects their eating. Stop the weight regain, and even gradually continue to lose weight. So we encourage those who suffer from binge eating disorder to join and participate in our group program. Thank you.